Good morning. Continuing from where we left yesterday, we will now take a look at the individual groups of antimicrobials and antibiotics. In today's session, we will be discussing sulfonamides along with trimethoprim. At the end of this session, you will be able to describe the mechanism of action of sulfonamides and trimethoprim, describe their spectrum of activity, mechanism of action, uses and adverse effects. We had mentioned Prontosil, which was developed and discovered by Domark, a German pharmacologist in 1935. The classification of sulfonamides is based on their duration of action. First, we have the short-acting sulfonamides, which act for up to 6 hours. Examples include sulfadiazine and sulfadimethyl. Intermediate-acting sulfonamides include sulfamoxazole and sulfamethoxazole, whose duration of action is about 12 hours. The long-acting sulfonamides, which act for up to 1 day, that is 24 hours, includes sulfamethoxine and sulfadimethoxine. Along with these three, included in the group are the topical sulfonamides, namely silver sulfadiazine and methionine, which are used for burns, and sulfacetamide eye drops, which are used in trachoma. Sulfasalazine is also classified as a topical sulfonamide used for inflammatory bowel disease. Now coming to the pharmacokinetics of the sulfonamides. Sulfonamides are rapidly absorbed on oral administration, and depending on their plasma protein binding, they are classified as short-acting, intermediate-acting and long-acting, which means the short-acting sulfonamides are rapidly absorbed and rapidly excreted, concentrated in urine and excreted either unchanged or as metabolites. If the urine is acidic, there is a chance of crystals forming in the urine, that is crystalluria. To prevent crystalluria, urine is alkalinized during sulfonamide therapy. This is a 3-mark question. The mechanism of action of sulfonamides. To understand the mechanism of action, one needs to know that the bacteria are capable of synthesizing their own tetrahydrofolate from PABA, that is para-aminobenzoic acid. So the first step in tetrahydrofolate synthesis is PABA is converted to dihydrofolate by the enzyme dihydrofolate synthase. And dihydrofolate reductase converts dihydrofolate to tetrahydrofolate. And as you know, tetrahydrofolate is important for purine and pyrimidine synthesis and ultimately DNA synthesis. The sulfonamides inhibit the first step, that is, sulfonamides inhibit dihydrofolate synthase in bacteria. The second step in tetrahydrofolate synthesis, that is conversion of DHF to PHF by the enzyme DHF reductase, is inhibited by trimethoprim. Individually, sulfonamides or trimethoprim, they are bacteriostatic. When the combination is used, it causes a sequential block of folate synthesis, thus becoming bactericidal. So this is an example of a combination of two static drugs becoming cidal synergistic effect. This is referred to as sequential block of folate synthesis. And this combination of trimethoprim and sulfamethoxazole is called co-trimoxazole, which by itself is a 5-mark question. Now coming to the spectrum of activity of sulfonamides. Sulfonamides are effective against gram-positive organisms, effective against E. coli, Haemophilus influenzae, Nocardia, Actinomyces, some chlamydia species, and Pneumocystis jirovecii. This is one of the causative opportunistic infections in HIV patients. Trimethoprim, the mechanism of action is it inhibits the second step in tetrahydrofolate synthesis in bacteria, that is by inhibiting the enzyme dihydrofolate reductase. Trimethoprim alone is bacteriostatic. When combined with a sulfonamide, it becomes cidal. Like we mentioned earlier, this is a synergistic combination. So a combination of trimethoprim and sulfamethoxazole is called co-trimoxazole, which causes sequential block of folate synthesis in bacteria. The ratio of trimethoprim to sulfamethoxazole is 1:5. Now this 1:5 combination in the tablet or the syrup produces a plasma concentration ratio of 1:20, which is found to be the maximum or optimum concentration to exert its cidal effect. So co-trimoxazole is available as 80 mg trimethoprim plus 400 mg sulfamethoxazole, or co-trimoxazole double strength 160 plus 800 milligrams. Coming to the adverse effects of co-trimoxazole, that is sulfonamides and trimethoprim, more or less common side effects. Crystalluria. Why does crystalluria happen? The metabolites of sulfonamides in an acidic environment, that is in acidic urine, can form crystals. Another rare but dreaded adverse effect is Stevens-Johnson syndrome. Equally potentially fatal adverse effects: agranulocytosis, allergic skin reactions, more commonly the fixed drug eruptions, photosensitivity reactions. So these are the adverse effects of co-trimoxazole, more specifically the sulfonamides. The uses of co-trimoxazole, like you have learned in microbiology, E. coli is the commonest causative organism of urinary tract infections. Prostatitis, respiratory tract infections, shigellosis, typhoid fever third line, gonorrhea, chancroid and meningococcal meningitis. High-dose co-trimoxazole is used in pneumocystis jirovecii syndrome infections in HIV patients, in trachoma, burns and inflammatory bowel disease. Another example for sequential block of folate synthesis is the combination of dapsone and 5-methylene in the treatment of chloroquine-resistant malaria. So if there is a 5-mark question on sequential block of folate synthesis, the student needs to write about trimethoprim sulfamethoxazole and dapsone and 5-methylene. Thank you. So the questions from this topic include mechanism of action of co-trimoxazole and sequential block of folate synthesis. And co-trimoxazole by itself is a 5-mark question.